I'm Rod Rourke. I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Drs. Jordan Frey, Chad Purnell, and Dr. Shuja Shafqat. Please enjoy.
Hey everyone, and welcome to the June 2017 edition of the PRS Journal Club podcast. My name is Shuja Shafqat, PRS resident ambassador from Lehigh Valley, and as always, I'm joined by my co-resident ambassadors Jordan Frey from NYU and Chad Purnell from Northwestern. Today we have the honor of being joined by Dr. Deb Johnson, current president of the American Society of Plastic Surgeons. Thank you so much, Dr. Johnson, for joining us for this PRS Journal Club podcast.
It's my pleasure.
The article we'll be discussing next is Breast Cancer After Augmentation, Oncologic and Reconstructive Considerations Among Women Undergoing Mastectomy by Eugenia Cho, Ronnie Shamas, and Drs. Phillip, Greenup, Huang, and Dr. Hollenbeck from Duke University. Remember, all of this month's articles can be read for free on prsjournal.com, including all of the past Journal Club articles. If we look at the current rates of breast cancer and patients undergoing cosmetic breast augmentation, about 35,000 augmented patients will be diagnosed with cancer per year and be seeing all of us for potential reconstructive options. We know from studies in the past that subglandular implants may limit detection of cancer on mammogram, but we have yet to determine if a later stage of disease presents in those patients due to that limitation. So the purpose of this author's study was to investigate the detection and management of breast cancer in patients who had undergone prior augmentation. They performed a retrospective review of 89 patients who underwent mastectomy for either invasive or in situ breast cancer diagnosed after they had had a cosmetic bilateral augmentation, and they looked at those patients over a period of 21 years. They also looked at 171 patients who underwent mastectomy who did not have a previous history of augmentation. And the two groups were compared for patient characteristics, detection method, whether it was self-exam or screening mammogram, stage of diagnosis, cancer treatment, including chemotherapy, radiation, and or mastectomy, reconstruction versus including no reconstruction, implant-based, autologous, combined, and immediate versus delayed reconstruction. For the augmentation group, they noted the characteristics of the implant, including the type, the volume, the location, pocket of the implant, the date of the augmentation, the time from when they had their augmentation to their cancer diagnosis, and when those implants were removed in their process. And then they separately compared patients who had subglandular versus subpectoral augmentation. They also looked at surgical margins after the mastectomy, and they assessed complications of nipple and mastectomy flap necrosis, infection, and implant loss. So as expected, a majority of the patients who had prior augmentation had subpectoral implants placed, and most of the patients who had detected their cancer were detected by self-palpation, and the average time from augmentation to cancer diagnosis was about 14 years. When they compared women who had prior augmentation to the women who did not have a prior augmentation, they found that the prior augmented patients were younger, had a lower BMI, and more likely to identify as white. And they underwent more bilateral mastectomies and more likely to undergo implant-based reconstruction, specifically two-stage methods. There's no difference between the groups for stage, cancer characteristics or treatment, detection method, or timing of reconstruction. When they compared women who had subglandular versus subpectoral augmentation, they found that subglandular augmentation was associated with more advanced stage cancers, specifically stage 1, 2, and 3 invasive, versus in situ cancers, and were more frequently found on self-exam. Subglandular patients also more commonly underwent direct-to-implant reconstruction compared to subpectoral, which I found actually most surprising. An overwhelming majority of patients had their implants removed at the time of mastectomy on the cancer side, but on the contralateral side, it was much more variable, and actually 18% of the contralateral implants were not removed at all. Patients with a prior subglandular augmentation also had higher rates of infection and implant loss, but 2 out of the 3 cases that did have implant loss had radiation as part of their treatment. So in the discussion, they state that their data strongly supports that there is no delay in breast cancer diagnosis after augmentation compared to the general population, and state that there may be a potential benefit for subpectoral over subglandular augmentation for screening purposes. They also state that patients with subglandular implants, and specifically patients who have Baker grade 3 and 4 capsular contracture, should have a way increased vigilance in screening of their breast cancer. And they actually go so far as to state that the decrease in efficacy of the screening mammogram in subglandular implants may be related to increased capsular contracture rates, but also that more masses may be detected on self-exam due to underlying implant pressure, though neither of these statewide invasive cancers were more diagnosed in these patients. Consideration should be given for subpectoral primary breast augmentation in patients who are at a higher risk for cancer, according to the authors. They also go on to discuss their findings about reconstructive options, and they state that implant-based reconstruction is safe in the previously augmented patient, and that prior augmentation may provide a delay type phenomenon to the mastectomy flap or provide some sort of pre-mastectomy expansion. They did note that direct to implant occurred more in subglandular patients, which I thought was surprising as the subpectoral pocket wasn't already developed in those patients. And then they discussed their limitations, including the retrospective nature, that the two groups are kind of inherently different, even in their patient characteristics. They couldn't look at capsular contracture rates, and that the population of complications in previously augmented women undergoing implant-based reconstruction was small, so the results may be skewed. So overall, I thought this was a really excellent paper, and for me, shed a lot of light on something that I have found patients tend to ask a lot of questions about. One of the things I thought is that some of the conclusions may be difficult to state since the pathophysiology and natural history of breast cancer is so variable between patients in terms of type and how it may present. And I would have liked to see a comparison between different cancer types, but likely their population numbers would have been small for any meaningful analysis. Also, as we know, they state that there may be potential benefit to subpectoral augmentation in regards to mammogram effectiveness, but in table 2 in the paper, an almost equal number of cancers were found on mammogram versus self-exam in the subpectoral group. So yeah, the mammogram may be more effective since a higher percentage of the breast tissue might be visualized with subpectoral implants, but in their study, it didn't seem overwhelmingly so. Also, I think they made a good point about patients with previous augmentations being more breast aware, quote unquote, and more likely to seek treatment for changes that they detect themselves rather than are found on screening mammograms. So to me, it would have been interesting to note if those patients with a new cancer diagnosis after augmentation presented more to a plastic surgeon or the plastic surgeon that performed their augmentation versus another physician. So I'll turn this over to the group, and Dr. Johnson, I'd be interested to hear what you thought of this paper. And my first question would be, do you have a general approach or discussion with patients presenting with a cancer diagnosis after augmentation, and how does your discussion change if they have implants already versus if they don't?
I think it's interesting because when we're putting in breast implants, it's often a younger population. They're not thinking about developing breast cancer at some point. But I think that has to be a part of your informed consent discussion to say, as an American woman, you have a 12% risk of developing breast cancer, and having implants does not increase your risk of breast cancer, but it also doesn't decrease it as well. And so we have to be very aware. I counsel my patients to relearn their self-exam after their augmentation because it does change kind of the palpability of their breast. I think the idea that many of these cancers were discovered by palpation was interesting, but then you think about this population of usually hypomastic women who don't have a lot of fatty tissue in their breast, and so they're going to be able to feel things a little bit better than somebody with a larger, fattier breast. So that sort of made sense to me. I do certainly tell patients that I believe that subpectoral augmentation provides better mammograms. And we discuss the fact that, by the time they need mammograms, there may be some different technology that we're using at that point. But certainly presently, mammography is better if the implant is a little bit separated from the breast tissue. Certainly a woman who has a positive family history of breast cancer, in a mother or a sister, I would strongly counsel them to put subpectoral implants in, and also to use saline implants, just because mammography is better with saline rather than the silicone. So those are things to think about in the younger patient, depending on their family history. And then once a patient presents with a breast cancer, one of the things that I tell patients is, if you ever feel anything in your breast that causes you concern, I suggest that they come to see me first, because sometimes it's related to the implant and you can quickly allay their fears. And I worry that if they go somewhere to a doctor who's not comfortable feeling implants, they may alarm the patient unnecessarily, or God forbid, do a needle biopsy and puncture an implant. So I do encourage patients to come back and see me in those cases. and tell them that we can allay their fears if it's implant related. If it's not implant related, a lot of times, I can do an evaluation more quickly and more cosmetically than some other places. So it wouldn't surprise me if some of these patients did seek attention from their plastic surgeon once they found a lump in their breast, because that would seem to be kind of a natural way to pursue things, to make sure that it wasn't implant related, and that your plastic surgeon who's comfortable feeling a breast with implants would be able to diagnose you efficiently. Once a patient has a breast cancer and they have implants in place, I think that this is sort of how I got started in direct to implant, because it seemed like a pretty easy leap to go from a subpectoral augmentation implant to a subpectoral reconstructive implant after a mastectomy, because you could just swap out the smaller implant for a larger size at the same time as the mastectomy. You've already got a capsule, so the implant's well protected, and you're less concerned about, if you have difficulty with your mastectomy flaps healing and that sort of thing, compromising your implant. I was a bit surprised that they talked about direct implant in the subglandular patients, because those, you're having to make a new submuscular pocket, perhaps using ADM, or you're doing a subglandular implant reconstruction. And we all know that that's become a bit more popular in recent years as well, as people are a little less nervous about putting things subglandularly if they feel that they've got good mastectomy flaps. The interesting thing, I think, in this study is that the long time frame of the patient population, started in 1993. And so breast reconstruction has evolved during that time. In the 90s, I think almost everybody was doing two-stage reconstructions and didn't even start offering direct to implant until probably the last 10, 15 years. So that may have skewed some of their statistics as to how the patients were reconstructed, depending on what was the operative choice of the day when those patients were diagnosed.
I think that those are some really good points, and I found it interesting that you talked about the self-exam, because they specifically mentioned in their discussion that people have gone away from teaching that because of false positives and things like that, and that you recommend patients go back to that. And the saline implant thing is also really interesting, and I'd never thought of that before. I was surprised that they did more direct to implant than the subglandular. One thing I wanted to ask is, with a patient who comes in, they had a previous augmentation and they're getting a mastectomy, do you do anything differently technique-wise? Do you find that you see more nipple necrosis or less nipple necrosis due to the previous implant placement? And then the one thing I wanted to ask, and you kind of mentioned that about swapping out the implant if they had a subpectoral augmentation. They mentioned in their discussion that if the patient had a subglandular implant, they didn't say completion capsulectomy, but they said they did a capsulectomy. And then for the subpectoral, they basically did a capsulotomy. Would you still use ADM in those patients, or would you use the capsule as almost your partial submuscular plane for your reconstruction, whether it's a tissue expander or an implant?
It depends on the anatomy of the patient. Direct to implant always requires a patient with, an appropriate base diameter and an appropriate volume with good quality skin. And so if they've got a 200 cc implant with a 100 cc breast, swapping it out for a 300 cc implant is a pretty easy thing to do. If they've got very large implants and a small breast, then sometimes, you could even leave that same implant in and have them not lose that much volume. So it kind of depends on what the patient looks like and what their anatomy looks like, and whether you can get a good fit implant-wise that's going to suit them. Usually in the subpectoral patients, if they've got a large enough capsule, then swapping for the larger size with perhaps a capsulotomy is pretty easy. Sometimes just doing a circumferential capsulotomy will give you enough breathing room to put in that larger size and still give them adequate projection. If they've got a tight capsule, then you're a little bit more stuck. And so you may have to do at least, an inferior hemisphere anterior capsulectomy and perhaps replace it with ADM in order to get the projection that you want in the lower pole if you're trying to do a direct to implant. I think if you're subglandular, then you may want to use some ADM in the lower pole, if you're at all concerned about coverage issues, not trying to avoid some scalloping or pleating of the implant. Usually In the subglandular patients, I've removed all of the capsule and converted them to a submuscular in most places. The idea that they had more healing difficulty in the subpectoral versus the subglandular, I found somewhat surprising. You'd think that an augment is going to delay the skin, if you will, a little bit because you have lost some of those perforator vessels that travel from the more centralized area of the breast when you put in an implant. So you'd think that the flaps would be a little more robust, but it varies from patient to patient, and it certainly varies depending on the general surgeon and how thin they make those flaps.
Those are all really good practical pointers for people, especially for younger surgeons and us going on to perform these. So, Chad, what did you think of this article?
I thought this was a great article. I think this is a tough problem to answer, really, like following these patients who've had augmentation and looking at their breast reconstructive outcomes. Ideally, this is something that can be answered with a long-term prospective study, but those kind of studies are really challenging to do. I think that this really is the best evidence we have right now as to how these patients do after they're having breast reconstruction. So I think this paper is a really powerful tool in helping us counsel patients before they get a breast augmentation, and also if they've already had a breast augmentation, if they're going to have reconstruction. The question I had for you, Dr. Johnson, was whenever you're dealing with these patients who've had a breast augmentation prior to reconstruction, what do you do on the contralateral side? Do you remove their implant at the time of the mastectomy, or do you try and address the contralateral breast in a second stage after the initial reconstruction is settled? What's your preference for those patients?
You know, it depends. Sometimes the patients will opt for bilateral mastectomy. I'm not a big fan of bilateral mastectomy because I do believe that if it isn't broken, don't fix it. And I hate losing, a sensate sexual part because of fear. But there are a lot of women who, once they get a cancer diagnosis, they just want to be rid of their breasts and not run that risk in the future on the contralateral side. So sometimes, you do a bilateral reconstruction after a bilateral mastectomy. If they have an implant in place that is comfortable for them, they've got a good capsule, they don't have problems with that implant, I would probably just leave it alone. In patients that I do end up doing some sort of balancing augmentation on the opposite breast, I usually do suggest that we use a submuscular saline because we do want to make sure that their mammograms are as effective as possible. If someone's very concerned, about they want to keep their natural breast but want to make sure that they maximize their ability to police that breast, and they had a subglandular silicone, you might suggest switching it to a submuscular saline in order to just be able to maximize the policing of that. So I think it just varies from, you have to lay out the options to the patient and have them weigh the pros and cons and what their risk acceptance is and go from there.
Great. Those are some great tips. Thanks a lot.
The thing I thought that was really nice about this article was that it did show that, although breast cancer occurs in augmentation patients, their diagnosis was achievable and prompt. There didn't seem to be real delayed diagnosis, although there was a little bit higher tendency towards invasive cancer diagnosis in the subglandular patients, because the population's small and we don't, it's hard to tell whether that's really going to be proven out under large numbers. But I thought it was comforting that women who have an augmentation are not putting themselves at significant risk for delayed diagnosis or a worsened prognosis.
Jordan, what did you think of this paper?
This was an interesting article. I agree with everything that's been mentioned. I think it is a unique subset of patients, and it's something that I'm sure patients are interested in. And as we're doing more and more of these procedures, we've seen, and it was mentioned earlier, the popularity of breast augmentation. Patients will be coming into the office. And Chad, you alluded to this, and it's kind of been a constant theme that we've seen as we're reviewing these articles every month, that this is a good article. It gives us a sense of the picture and begins to make things clear, but it can be tough to do larger studies, but there may be a need to do more so we can really establish what this risk is or kind of what the natural progression is or how these patients will present. So Dr. Johnson, what do you think about that in general and specifically for this problem? Should we be compiling a nationwide database or how should we be looking at this?
one of the nicest things that we have coming forward is the National Breast Implant Registry, because right now, unfortunately, patients get augmented, their implant information gets sent to the manufacturer, but then the patient disappears, they move, they get married, you don't really know what happens to them. And I think that the National Breast Implant Registry is going to be a quantum leap in being able to gather data about the lifetime of an implant, because we'll be able to follow these women from the time of their augmentation through any subsequent procedure regarding their breasts. So it'll track according to Social Security numbers. So whether they change their name or they move or whatever, we'll know what happens to them. And that's going to be, a huge data repository for us moving forward, knowing, who gets diagnosed with breast cancer and what happens to them. So I think that it is tough to run these kind of studies, in your own individual practices, because it's a long time from augmentation to perhaps diagnosis of breast cancer. Your numbers are small, and it's hard to get patients to come back year after year after year. So I think that the NBIR is going to be a real treasure trove for us in the future of being able to follow these implant patients and knowing what happens to them.
This is Shuja again. I think that was a really good discussion. I think this article gives us a lot of good details, especially now that the media has kind of hooked onto this concept of ALCL and potentially confusing a lot of patients about what type of cancers come when. I think this is good information for us to have. So I think that was full of really good practical details. But I think with that, we'll end our discussion of this article. Remember, everyone, to tune into the other two articles we'll be discussing on this month's podcast, as well as all of our previous and future podcasts broadcasted every month. And also don't forget to participate in our monthly hashtag PRS Journal Club on Twitter, where we'll be able to interact directly with this month's selected articles' authors. And once again, thank you very much, Dr. Johnson, for joining us today.
Oh, it's been great. Thank you very much.